And lastly, for those who are invited to the meet and greet session after the presentation, please remain on the Zoom upon completion of the Q&A. So for the next 30 to 40 minutes or so, we will be hearing from Dr. Joseph Betancourt, who is the president of the Commonwealth Fund. He formerly served as the Senior Vice President for Equity and Community Health at Massachusetts General Hospital and as Founding Director for the Disparities Solutions Center. He has devoted his career to improving the quality and the value of healthcare for diverse populations. He has served on committees that have advised all agencies within the U.S. Department of Health and Human Services, including CMS, the Agency for Healthcare Research and Quality, the Centers for Disease Control and Prevention, and the Health Resources and Services Administration. His roles in governance have included serving on the board of Trinity Health, Neighborhood Health Plan, and the Massachusetts Health and Hospitals Association. Dr. Betancourt is an associate professor of medicine at Harvard Medical School and a board-certified internist, providing primary care to a large Spanish-speaking and minority patient panel. Following his residency in internal medicine at New York Hospital Cornell Medical Center, Dr. Betancourt was a member of one of the first classes in the Commonwealth Fund Fellowship in Minority Health Policy at Harvard University, where he earned an MPH in Health Policy and Management from the Harvard T.H. Chan School of Public Health. An author of nearly 90 peer-reviewed articles, he has served on several Institute of Medicine committees, including the committee that produced the seminal report, Unequal Treatment, Confronting Racial Ethnic Disparities in Healthcare. Dr. Betancourt is an Aspen Institute Health Innovators Fellow and recipient of the Sumner M. Redstone Endowed Chair in Health Equity at Mass General. In 2023, he was named one of modern healthcare's top 50 clinical healthcare executives in the United States, and in 2024, named one of the top 100 most influential people in healthcare. He's a member of the National Academy of Medicine. We welcome Dr. Betancourt.
Thank you so much, Dr. Macias. I appreciate that kind introduction. Thank you all for taking time out of your schedules to be with us here today. I hope to make this an interesting conversation, really talk about an issue that is near and dear to my heart, the area of primary care, and get a chance to engage you in conversation as well. I think I'll begin by telling you a little bit about where I'm from and what I do above and beyond what you've heard from my bio. So I'm originally from New York City. My family's originally from Puerto Rico, immigrated to New York in the late 1950s, worked primarily in blue-collar settings, and I spent the first 7 years in New York. I say this only to say that I am new and first in my family to enter the health professions, and really think that occurred as a result of a lot of sacrifices by family and others. So I always like to, honor their sacrifices and all the things they did to give me the opportunity to dream about becoming a doctor and to keep me in situations where I was safe and focused on education. I lived in New York till I was 7, lived in Puerto Rico till I was 10, and then returned to the New York area. And maybe the first inflection point in my life was around that time where I developed a passion for becoming a doctor. I'll just say that not having come from a family of caregivers or many who'd been in the healthcare space, it was more a dream without all the different components to it. I don't know that I fully understood everything about what being a doctor was about, but I certainly had a passion for science, and I had a passion for engaging people. I was very curious. And so I think it was there that the seed was planted for me, that I was committed to pursuing a career as a doctor again, and probably in junior high school. A bit of a kind of naive, I guess, choice to some degree, not fully informed, but one that I'm really proud I followed up through in my career. For me, I think I came from a family who both was avid as it related to organizing vulnerable communities for their rights. My father, an organizer of minority workers in the workplace. My mom really focused on helping community members. So with that kind of genetic imprint, I went to the University of Maryland, then went to medical school at Rutgers in Newark. It's a big second inflection point for me, where in Newark, New Jersey, a primarily minority underserved city and community, a couple things became very clear to me. Number one, as I looked around at my colleagues, there weren't a lot of people who had my lived experience in that I think was an interesting observation for me. Second, the simple fact that I grew up speaking Spanish and I had a window into different cultures and spoke a different language made me quite valuable on rounds in ways that some of my other colleagues weren't. And it gave me also a sense of responsibility, given that I had these sets of skills and that I could merge them with the clinical skills I was building. And then I guess finally, at that time in my career, I began to see how patients of different backgrounds receive different quality of care based on their race, ethnicity, gender, socioeconomic status, other factors, how personal characteristics actually did play into the quality of care patients received. Not at all casting blame. I think we had people who care deeply, and so it wasn't about any one suspect or any one solution. There were systemic factors, there were factors related to insurance status, and certainly there were factors related to trust, language, how well we communicated, some assumptions that were made about patients that led to what we call today disparities or the area of health equity. It was at that time that I decided to pursue a career in this space, thinking that as opposed to just seeing patients one at a time, that I wanted to broaden my aperture, have greater impact. And I began to think about a master's in public health, particularly in health policy and management, ways in which I could really expand my influence, bringing my skills and talents to improving the care of everyone, but particularly vulnerable populations. And had a chance to do my internal medicine training at Cornell in New York City, where I was able to build my portfolio in that space. And I'd say a key lesson for me during that time was really trying a lot of things, trying research, trying work in community health, trying really digging deep in patient care and really figuring out what I enjoyed and what my strengths were. I reflect a lot back at that time because I think it was a result of trying a lot of different things that I, again, figured out the intersection of three important areas that have been critical to giving me a career that I'm blessed to have. One, being able to work in an area that I'm passionate about. So I think if you could align your career with the work that you're passionate about, it's no longer work, it's a joy. I'd say second, being able to work in areas that are your strengths, and it takes a while to discern that, trying different things, figuring out what you like and don't like, and figuring out what you're good at. If you're able to work in a situation where you're leveraging more often than not your strengths and your weaknesses and are able to build a team to supplement you and to build out and address any weaknesses you might have, again, that's a wonderful blessing. And then finally, a third part that you learn over time is how do you like spending each day? Do you like bouncing around? Do you like being focused? And I think through all those, I would call them life experiments, I was able to align a career that focused on areas that I'm passionate about, more often than not working at things that are towards my strengths and really enjoying my day to day, which is bouncing around, doing different things and engaging people. So I had a chance, as was mentioned, to build my skill set and career development at the Harvard School of Public Health with a particular focus on health equity. And this was in the late 90s. And since then, really had a chance to, within the academic health center setting, particularly at Mass General, where I spent over 20 some odd years, build and develop a career that began with some research, advanced to some really significant quality work, grew to a national portfolio with engagement in national organizations and the creation of the Disparity Solutions Center, and then moving into executive leadership as Senior Vice President for Equity and Community Health. I guess bringing us to the content of our talk today, I have always been and remain to this day a primary care doctor. I still see patients a half day up at Mass General and spend about 90% of my time in New York. But when I departed Mass General in 2023 to be president of the Commonwealth Fund, I developed very significant relationships with my patients, and it's not something that I wanted to let go immediately. So I continue to engage in that work. It's very meaningful to me, and I think it informs a lot of the other work that I do. And so it's with that I humbly embark here on a conversation about primary care and a bit about where we are with primary care and a talk entitled Primary Care, the Promise and the Peril. Let me begin by telling you a bit about the Commonwealth Fund. The Commonwealth Fund touched my life very, very early on. The fellowship that I did after I finished my internal medicine residency was sponsored by the Commonwealth Fund, Harvard University Fellowship in Minority Health Policy. I was the second class of that fellowship. And so the Commonwealth Fund has played a special part in my life. A bit about the Commonwealth Fund. This was a foundation, very importantly, that was founded by a woman, Anna Harkness, in 1918. Fundamentally, her view was that we needed to do more to improve the health and well-being of mankind, of humankind. And she set aside $10 million at that time to create philanthropy that would both give grants, but also create reports and really track and set a course for American and international healthcare at that very early day. I like to draw back to our history and say that the Commonwealth Fund has been very, very influential. Its mission has been affordable, high quality healthcare for everyone. At the turn of the century, we funded the nation's first public health departments, the nation's first rural hospitals that led to the Hill-Burton legislation that provided federal funding for building the hospitals nationally. We funded the first advanced practice practitioner programs, first medical schools in urban areas. We funded the first palliative care program. We funded a little bit of science, the science that led to the cervical cancer screen. And we pivoted more strongly to policy in the 80s with a particular focus on 80s and 90s and 2000s on healthcare reform and a lot of the research that undergirded the Affordable Care Act. Our impact framework is built in 3 areas: policy, practice, and leadership development. We have a team of about 45 people, about 30 some odd in New York, about a dozen in DC. And again, we give out grants. About half of our $50 million budget every year is for grant making. The other half is to power our internal team. We focus on the following areas: healthcare coverage, Medicare, Medicaid, employer-sponsored insurance, and affordability. We focus on care, particularly focus on primary care, rural health, and health equity. We focus on healthcare costs, commercial drivers of health, commercial prices, prescription drug prices, and we have a small portfolio on decarbonization of the healthcare system. And we have international work as well, sharing and learning. So it's a real privilege to lead the Commonwealth Fund. I began again this job in January of 2023, and we are just about to launch our next chapter, charting our path to the future. I've mentioned primary care being a really important part of what we do. Personally, very, very important to me. And so I'd like to now give you a brief sketch of kind of where we are. And I'd like to begin with where we are as a nation as it relates to healthcare. And I think it's really important to understand that the United States, compared to its peer nations, other OECD nations, spends the most in healthcare. And so when we compare ourselves to other nations here, you see that trajectory. You see how we compare to other nations, but there's no doubt that we're an outlier in healthcare spending, and we spend the most compared to our peers, as I mentioned. Now, the interesting part about that, and perhaps the unfortunate part about that, is despite spending the most on healthcare, we also get the least for it. We have life expectancy at birth that's 3 years lower than the OECD average. We have individuals in the U.S. compared to other nations most likely to have multiple chronic conditions. The U.S. has the highest rate of infant and maternal mortality, and we have profound racial, ethnic, socioeconomic, and geographic disparities in health and well-being and life expectancy that have long been the norm. So the issues of kind of health equity across multiple characteristics are profound and are real. So despite spending the most, we have the least to show for it. And I think this is an important place to start because it's not about not having the money, it's about how we deploy it. Now, when we think about a system in peril, and particularly primary care, we think about several things. First, it's important to understand that primary care is the only part of the healthcare system in which investments result in longer lives and more equity. It's foundational. So everything we do in health really focused on prevention, chronic disease management. And it's not just internal medicine and adult medicine. Certainly it's pediatrics, family medicine, maternal health care. So what do we see? What is the landscape of this very foundational component in the context of spending a lot of money but not having a lot to show for it? Well, we see in primary care that we underinvest and have low payment in primary care. And I'm going to double click on all of these areas in just a moment. We have an aging and declining workforce in primary care without reinforcements. We have more adults without a usual source of care than other comparator nations. We have too few physicians trained in community and rural settings and practicing in many of those settings. And we have very little federal funding for primary care research, how to make it more effective and efficient. And again, just lower investment in primary care in general. Let me walk through a little bit more detail in each of these areas to give you more context. So I guess the biggest thing that I draw your attention to is in the context of us spending the most, having the least to show for it, we begin to look at what's different between us and some of our peer nations. One, I'd say, is greater investments in the social drivers of health and the social safety net. So we'll set that aside here. We know how important the social drivers are to health and well-being, and our comparator nations make greater investments in that space. Number two, our comparator nations have managed to create systems of universal coverage such that investments in prevention, those investments, those return on investments are reaped by those same individuals, by those same organizations. In those cases, the way the healthcare systems are set up and the way their universal coverage is set up. So universal coverage, that connection between those individuals who invest in a person's health and the nation, getting that return on investment is connected. And that's what I'll refer to as universal coverage here. And those nations, again, have those systems in place. We have, as you all know, a patchwork system of healthcare coverage. I think, need to be very proud that in the last year, we reached unprecedented levels of the uninsured. We got up to 93% insured in the United States, both through the Affordable Care Act and things like Medicaid expansion. But despite that, real significant challenges around access to care and affordability that still require a lot of attention. But nevertheless, those are some of the key things that differentiate us between other nations. But here's another one very much related to primary care. Those countries, on average, spend 14% on primary care, whereas we here in the U.S. Invest about 5%. The United States also has the largest wage gap between generalists and specialists. Within the U.S., as I mentioned, not only is investment disproportionately low, but primary care accounts for 35% of healthcare visits, but only 5% of expenditures. And we know how important primary care is. Our surveys, Mirror and others, consistently find that the U.S. performs worse than our peers on access and quality of primary care as a result. Second, when we think about workforce, 1 out of 4 practicing primary care physicians are over the age of 65 and will be retiring in the next 5 to 7 years. 16,000 primary care physicians left the workforce between 2021 and 2022, built already on a 10% decrease in the primary care workforce from 2005 to 2015. Now, we see this decline in the workforce due to a lot of different reasons. And I would argue that the remaining workforce is dealing with a lot of different challenges, particularly coming out of COVID, a lot of demoralization. Working in COVID, myself personally on the front lines, a time where I call the worst of times for all the reasons we know, but also the best of times, because we were able to do everything, every minute, to save lives and to help patients, to cut through bureaucracy, to do everything we could aligned for the greater good. And we now return to a system that brings back that bureaucracy, that has us dealing with a lot of challenges that prevent us in our encounters with our patients as providers from getting them the things they need often. And that is very, very demoralizing. And there's a lot of different barriers in the way from us doing what we've devoted our careers to try to do. And so we're feeling that demoralization nationally, and I would argue that it's leading to a lot of different things, including unionization, but also exiting from the profession and or limiting hours devoted to work. Second is administrative burden. I think these are connected. The amount of administrative burden has increased. We live in a time of incredible information, but I would argue incredible information overload. And that has led to just incredible burnout and loss of agency. And we're also working at a time where many would argue the pendulum has swung quite a bit, really putting profit and revenue over patient needs. And so all these things, I think, are having a very significant impact on the workforce and its decline in primary care. When we think about access, again, health insurance does not meaningful access make. And although we've done a great job at coverage, we know that the amount of people without usual care is rising and wait lists are growing. You could go to any city around the country, and certainly in rural areas, and the wait times to see a primary care doctor could be months. And again, this is acute in rural parts of the country and in underserved communities. And so when we compare ourselves to our peer nations, when we survey around having a usual source of care, a longstanding relationship with a primary care provider, we tend to do significantly less well than other countries. So maybe I'll talk about reinforcements here. Primary care provider pipeline is limited and falling. Why? Well, we have students who are making choices based on two particular areas. Number one, quality of life and joy and sets of satisfaction. And we have our medical students looking at primary care and understanding that despite being very mission oriented, those students are able to see that burnout, able to see that demoralization, and are, as a result, making other choices. We also see that the issue related to compensation absolutely plays a role. Students are emerging medical school with significant debt, needing to make some choices based on, their long-term remuneration, and primary care compared to other specialties is lacking. And so the primary care provider pipeline is limited. Only a small proportion of primary care residents, individuals who go through residencies focused on primary care, end up practicing primary care 3 to 5 years after residency. In fact, nearly 90% of internal medicine residents go on to subspecialize. And I would also say that there are few federal funding opportunities for primary care research. Obviously, that's a greater threat now. Only 0.2% of NIH funding allocated to primary care in particular. And we look at here growth in the number of primary care residents per capita, not keeping pace with other specialties. So now I'll pivot here to talk a bit about the promise. What are the things we should be doing, the ways in which we could be fortifying primary care? And I'm happy to say that there is greater attention to this now. There's bipartisan interest. The current Secretary of Health and Human Services has signaled that primary care is an important area that should be receive greater investments. I think we're seeing a tipping point of patients, of individuals really being frustrated with their lack of access to primary care. For all those reasons, we might be getting to a situation where there might be opportunities at the policy space to do better for primary care, to increase our investments in primary care, and to address a lot of the challenges that I've shared with you here today. So a bit about the promise. The National Academies of Science, Engineering, and Medicine, NAM, National Academies of Medicine, released a report a couple of years back on kind of 5 key objectives for improving primary care, and I'd like to talk about them quickly here. Number one, a big challenge that we face in primary care is how we finance it. And so as opposed to, and I'll talk about this more in a minute, paying for quantity, how do we shift to pay for quality and team-based care and value? So one of the key recommendations was to pay for primary care teams to care for people, not doctors to deliver kind of onesie-twosie services. The second is really to assure that we are connecting primary caregivers with people, and so that everyone, every family has a connection to high quality primary care in some way, shape, or form. Third is to really assure that we are training primary care teams to be the caregivers of the future and to be engaged where people live and work to make primary care accessible, meaningful access. Fourth, to design information technology that serves the patient, family, and interprofessional care team. I'll just say that I'm at a phenomenal conference here in San Diego right now called NextMed, where we are getting to see what the future looks like. It is incredible what artificial intelligence will give us a chance to do as a caregiver, decreasing our cognitive load, increasing our capacity, augmenting our ability for diagnosis and treatment, not to mention all we'll be able to do to get even more data about patients, to create more precision strategies, to leverage virtual and avatars and other technologies for healthcare coaching, for healthcare navigation. Really, the future is incredible. And what we've talked a lot about is the 3 key areas that are going to be important as we think about technology. The first is how do we better finance it and make sure that it's not just deployed for the haves and not the have-nots. We know that there's a diffusion lag for vulnerable communities. How do we prevent that through financing? The second is integration. How do we integrate it into clinical practice, and not just into some clinical practices, but all clinical practices, including those that are community-based in rural settings and they care for vulnerable communities. And the final part is, how do we democratize it? How do we really make sure that when we think about the kind of user experience, that we're building these technologies to meet the needs of everyone? That's the principle of equity, is meeting the needs of everyone and making sure that we are deploying systems to get high quality care and health and well-being for everyone. And so I think the promise of technology is here, the future is now, but it's how do we do that important work of making sure that we finance it, integrate it, and democratize it to really get the most out of it. And I think its potential in primary care is limitless. And then finally, how do we ensure that high quality primary care is really implemented in the United States in a more deliberate fashion? So just one slide here on payment as I get close to wrapping up. I mentioned most primary care providers are paid on a fee-for-service basis. This creates incentives for providers to deliver high-priced services, see more patients in a day, and it discourages the provision of non-medical services like care coordination, team-based care. At the Commonwealth Fund, we've been working in the policy space on value-based payment and how do we shift to alternative payment models that really think about not only greater investment in primary care, not only supporting the workforce and building the workforce, but reimbursing primary care with hybrid payment, a blend of per patient payments and fee for service that is more focused on value, global payment. So a bit in the weeds around this policy point, but at the end of the day, financing is quintessential to really getting the improvements in primary care that we're striving for. So I'll close out with what I think are some of the key areas around the promise. Greater investment in primary care we strongly believe will lead to decreased costs, and we need to get that primary spend higher. In California, the state I'm in right now, there's been a commitment to invest 15% of the state spend in primary care. Very, very exciting. We're seeing several efforts across states. And again, interest at the federal level in a bipartisan way on greater investment in primary care. So incredible promise there. Second, I strongly believe that primary care and the primary care team will expand to not only advanced practice practitioners, nurse practitioners, PAs, but also health coaches, navigators, digital navigators. Teams will evolve to a broader set of disciplines. It will allow all of us, including people like myself, to work at the top of our license, to decrease cognitive load, to kind of better level the different types of activities we have to do every day for our patients. And so exciting, team-based care will be really, really important. The third, as I've been mentioning now, AI and other modalities, absolutely, without a doubt, will increase the efficiency and effectiveness of care. I think the challenge is we don't want to backfill that with just more and more patients. At the end of the day, we will need to increase our capacity given the access challenges that patients face. But I really hope that with these technologies, not only will we do better by way of the care of patients, but we as caregivers can get to the business of caring more, of really kind of focusing on empathy, curiosity, respect, engagement, building trust, things that patients really want and are asking for. Virtual care, home monitoring, wearables will allow us to do more at home. Really, really exciting. Incredible data that supports how we could increase care at home, better outcomes for individuals who are cared for at home. Certainly, we need to think about the workforce implications of that and how family caregivers, how they will be burdened by this. How do we right-size that? But ultimately, our model of bricks and mortar care, I think, will evolve given these technologies. And I do believe what's happening in the genomic space and what's happening with precision medicine, what we're able to do with rapid diagnostics, what we're able to do with specific treatments will absolutely improve prevention and chronic care. This is happening fast. It's incredible. It's inspiring. It's exponential. It is, again, about financing, integration, and democratization. So I'll end here by saying that primary care is absolutely an essential service, but it is in crisis in the United States. There are multiple challenges that make the future of primary care perilous. Those are challenges that we're facing right now, but we absolutely must invest more, and pay smarter for primary care. And we must make primary care a career path of choice, letting individuals know that, yes, there is promise here. We could support you with a care team, with technology that could allow you to do meaningful work, that won't burden you administratively, that you won't feel demoralized, that you could have quality of life. We need to create that. And, it's essential for us to be able to address those things that are impacting our profession right now: administrative burden, demoralization, loss of agency, while also preparing for those tech advances and getting the financing right. This is the promise. This is the task, the set of tasks in front of us as we think about primary care of the future. So I thank you so much for your attention. We're right at the half hour here. Happy to take some questions. And again, want to thank everyone who was involved in inviting me and giving me a chance to share some things that I hope were hopeful. Happy to take questions, and thanks again for your time and attention.
Wonderful. Thank you, Dr. Betancourt, for a thought-provoking view of the landscape of primary care and strategies for impacting that space. We do have a few questions. I think the first launches off of something you referenced earlier as we think about technologies and advances that shift diagnostics. Can you speak to the movement towards home test kits being developed and pushed to testing into patients' hands? How will primary care professionals be impacted by this spread of control and autonomy, and what kind of work and rework does it cause for caretakers?
Yeah, I mean, if you think, let's say my practice, the amount of phone calls our office gets around a patient perhaps suspecting they might have a urinary tract infection. And now we'd like that patient to come in, leave a UA, get a culture. Oftentimes we might just go ahead and treat. And the simple ability for the person to get a home test and be able to report that to us. I mean, we saw this with COVID, the ability to give people a chance to COVID test and what we're able to do, test and treat. I mean, it's incredible. I in January was sick. Within 8 hours, had a COVID and flu A and flu B test in my hands. Did the test, knew I had the flu, and began treatment in hours. And so our ability, this is not a is it okay? This is not a how. This is a not an if. This is a when. And the question is spot on. How will we integrate it into our care flow? I would argue this is much more patient-centered. There's going to be a lot more of this. I think about what we'll be able to do in an area that I spend a lot of time on, which is blood pressure control, where ambulatory blood pressure monitoring will allow us to, with good fidelity, be able to really optimize a person's medical management for blood pressure control. Cardiometabolic disease being the quintessential and leading killer of Americans across the country. What we could do in that space, what we've done now with Cologuard and the ability for people to do a home test. I mean, the list goes on, and this list will grow. And I think it will really increase access. It will make it easier for patients. It will allow us to have less things get in the way, people falling through the cracks, not being able to follow up. So, and what I'm seeing here at this conference is just mind blowing. I will say it's when you see what's in the future, and again, this isn't the future of 5 years ago, 5 years from now. This is the future of now. You almost feel like you're practicing in the dark ages. It's phenomenal what will be and what's happening and what's coming. And so I think what we could do in the home and what we could put in the patient's hands will be a large part of that.
Another audience member writes, what are the political drivers or other drivers that are preventing primary care from getting adequate support? Where's the role of specialty societies, industry? Is it patient education?
Yeah, it's a big challenge. I mean, I think ultimately I open by saying that it's not about lack of resources. Right? We are not a country that could say, well, we're not investing in primary care because we have limited resources. We are fundamentally spending a lot and have the least to show for it on metrics that are really important, and people are feeling that. So anytime there's that much money in industry, there's a lot of people for whom change is very difficult, and change means loss. And so we see in various efforts around change, even at the large area of healthcare reform, those really kind of well-entrenched interests fight to the death to maintain their piece of the pie. And I think that comes at the expense of the American public and our health, to be honest, and our well-being as a nation. And so when we think about primary care, yes, I think we have had some forces that have, I think, advocated for themselves, which you might expect, at the expense of what is right for the American people. And so, yes, we will have to make some compromises here. So we have some political forces. Yes, when I'm on Capitol Hill, what I hear from legislators is that we hear more from specialists than we do from primary care as it relates to advocacy. And again, I want to be very, very sensitive to not pitching providers against each other. That's not my goal at all. Very close friends and colleagues who are specialists who do incredible work and should be compensated for that work because they've devoted, many years more than I have in training, in neurosurgery, orthopedics, and the list goes on. So this is not about begrudging anybody their investments or their rightful compensation. That being said, those interests drive to kind of keep the status quo, and that's a challenge. And so the hope is that we as a nation, both through patients and as providers, could be clear-sighted about how we can perhaps get some compromises in place. I don't know that it all has to come out of kind of right-sizing specialists and primary care providers. There's a lot of resources in the system. I think we could do this in a way where everybody feels well compensated, but we're really focusing on the things that make us a healthy nation. And so politically, I think advocacy for primary care needs to increase. I think we need to catalyze, quite frankly, the incredible dissatisfaction that patients are feeling across the country around lack of access to primary care. Just having people's voices heard about its importance. And I think we do need to engage across all disciplines of medicine and say, how can we make sure that everybody feels well compensated, is working at the top of their license, is making meaningful contributions to a healthier America? That's what we're trying to pull together. But I think as the question articulates, it is challenging, and it's the work in front of us.
So one viewer writes, how can we, individual stakeholders, support Medicare and Medicaid and other payers to reimburse healthcare providers at an effective rate, specifically for obesity, healthy eating, healthy activities, diabetes? I think this just comes down to the question of what can we do?
Yeah, so I think it's critical. I'd say several things. And you mentioned Medicaid. We're trying to really through our research, highlight how important Medicaid is. 72 million individuals. I think about 1 in 3 births care for individuals who are older, care for individuals with disabilities. Medicaid is a very important part of our coverage fabric. And I would argue a disruption to Medicaid will not just impact individuals with Medicaid, it will impact the entire healthcare system. We're yet to see where Medicare will go. I am pleased that this administration is talking about those exact things. How do we invest more in healthy foods and food as medicine and prevention and primary care? We have a lot to see. There's obviously incredible disruption right now. Not all good when we think about the things that are important for us, when we think about affordable, high quality healthcare for everyone. But there are those shining rays of light that we're hoping to leverage. What I think is critically important for us as primary caregivers is to do really 2 things. Number one, to help our patients understand in very simple terms and with humility what some of the key policy debates are about. We have many individuals across the country who have Medicaid who don't even know it because it's called something different in their state. Simply explaining to people more in very simple terms about the importance of what Medicaid is and how it impacts everyone, even if you have commercial insurance, is really, really critical. We become ambassadors there. And I think we need to say it. This isn't about me. This is about the health of the American people and people like you, all people, because cuts in Medicaid won't just impact individuals in Medicaid. So how do we serve as better ambassadors, build trust with our patients, and get them more activated about the simple ways in which they can, I think, let their representatives know about the importance of primary care, about the meaning of primary care. That's one. I think for us as primary caregivers, being active in advocating for primary care, for coverage, for greater investments in primary care. Again, I mentioned when I go to Capitol Hill, a lot of what the senators and representatives who I speak to say is, mostly who we have visiting us are specialists. And, rightfully so, specialists should advocate for themselves, but we need to advocate for ourselves and the American public as it relates to investments in primary care. So our playing a role at the State House, on Capitol Hill, is really, really important. We need to lift up our voices in a unified front. That we have the data, that those wins in our sales. And so bringing that data forward, I think, is really, really important. So those are 2 things that I would recommend.
Inspiring messages. Thank you. Well, our general time is up. So for our general audience, thank you for joining us. And for our research scholars, please remain on the line for our meet and greet. Just a reminder that the webinar is available on the University Hospitals Research and Education Institute website. Thanks again, Dr. Betancourt. And we will move right into our meet and greet.
Great. Thank you all. Appreciate you.